next. So it's my pleasure to introduce the final speaker tonight, Dr. James Berry, who is really going to piggyback very nicely on the last two presentations to talk about the current clinical trials. Dr. Berry has been pivotal in really building biomarker studies and leads the initiative at the NEALS biorepository, and is also involved in many of the clinical trials that he'll present to us tonight. So it's a real pleasure to introduce him today.
Yeah, so I think this is great. Lucy gave a fantastic overview of kind of what's going on in research, and Nick talked specifically about stem cells, which are always sort of a really hot topic. And one of the things that we're learning the most about, what I'm going to do is go through some examples of the kinds of trials that we're doing now. So it'll be sort of a hits list. It's not going to be everything, but I wanted to start by sort of highlighting a few of the wins that we've had in ALS. So Nuedexta is a drug that we can use to treat pseudobulbar affect, which is sort of an emotional lability or crying too much or laughing too much or in inappropriate situations. And it's a symptom of the disease. It's almost like a reflex. And it was really difficult to treat until a few years ago when Nuedexta, which was being studied to see what its effect was on disease progression, was noted to really have a huge effect on the symptom. And we now have a very effective treatment for this really, really bothersome and really, in some cases, huge quality of life problem for people with ALS. Mexilotine, and I'll talk about this study, has really shown that it's effective for cramping, which is another huge problem for some people with this disease. And then finally, we've begun using, and many centers have begun using video televisits, and I think this is something that's coming into its own in healthcare in general. But if we think about ALS, I think the exact symptom that we're treating is the symptom that makes it difficult to come into clinic. And this opens a whole new world for us to be able to reach people who are later in the disease, live further from a center, and just don't have the kind of access that we would like them to have to clinic. And so, already we can start our talk by saying that the clinical trials that we've done over the last few years have given us wins in this disease. And that's a really important message, I think, if we all walk out of here and are able to say that to people when we talk about this disease. It sets the stage that we are making progress and there's more progress to make. So I just want to keep that in mind. The other thing that's incredibly exciting is that the pipeline for ALS treatments is bigger and bigger. And this slide is already out of date. I made it a couple of weeks ago. It's already out of date because there are more that are not on this list. I'm not going to be able to talk about everything on this list, and it's a great feeling to have to come up here and talk about ALS clinical trials and be choosy, because it means that there's so much going on. So I'll talk about a couple recently completed ALS trials. I'm going to talk about some ongoing trials, and I'll talk about some trials that are coming down the pipeline. And again, I couldn't include everything. So there may be questions about things that I haven't talked about, and I'd be happy to answer those. So I'm also going to tie each of these trials in as much as I can to some of the biomarkers that they're being developed from. And I think this is a new trend in ALS, that we are developing biomarkers which are telling us about some of the potential underlying problems in the disease, and then we're going after those specific pathways with our treatments. So one of the things that came out of Stan Appel's lab down in Texas is that if we look at immune cells, there's a certain kind of immune cell called a T cell, and there's a subset of that that's called a Treg. And the job of regulatory T cells, or Tregs, is to damp down the immune system, to sort of keep too much inflammation from being around. And what he and his group found was that if folks had a decreased number of Tregs, or actually percent of Tregs, suggesting that they had more inflammation, the disease seemed to progress more quickly. So based on that, there's a group called ALS Therapy Development Institute, which many of you probably know, and they ran a panel of immune-active drugs in the mouse model. And they found that one in particular, called fingolimod, looked promising. Out of their whole panel was really the one that affected survival. They have a lot of experience in the mouse model, and they have everything in that experiment to go in the right direction. So it wasn't just survival, it was function, and it was how the immune system was behaving and so on. Now, it turns out that fingolimod is an FDA-approved drug, which makes it easier to bring to patients. It's faster than a drug that hasn't been approved by the FDA. And it's known to reduce circulating lymphocytes. So it doesn't have an effect directly, or it has an effect on Tregs, but it has an effect on all the lymphocytes, the sort of whole population. So what we found that we would be able to do is to sort of recapitulate some of the data that Stan Appel and his group had created in observational studies in a trial setting. So we could put fingolimod into people with ALS and then look at T-cell subsets and some of the RNA products that are coming out of those cells. And we'd get ourselves a biomarker early on while we investigate the safety of the drug. Because it turns out that the drug also has some side effects that we needed to be cautious about putting it into people. It can slow the heart rate, especially for the first day after people start it. And these are all well characterized, but we need to know how they behave in people with ALS. Maybe that's a more troublesome side effect in people with ALS. It also causes some swelling. It can cause some swelling of the retina and blurred vision. And that was something we knew we'd have to look out for. And finally, the FEV1, which is a pulmonary function test, took a very small drop in the MS studies. Now, MS is not a disease that early on causes difficulty with pulmonary function, but ALS is. So we really wanted to be very cautious about this. And we took a very sort of cautious approach. We did a 1-month trial. We involved approximately 30 people. 2/3 of them got drug, 1/3 got placebo. And our goal was really to investigate these things in a new population and get blood for biomarkers. And what we found was that the FEV1 actually didn't change in any meaningful way between the placebo and the treated group. You see the placebo actually went down a little bit more, but these lines here are error bars, and when they overlap, it means that there really isn't a difference. We did see that there was this drop in heart rate the first day. It wasn't problematic. Some people had a drop in their heart rate. They didn't feel any worse. There were a couple of people who said, gee, I'm a little lightheaded, but that went away very quickly. And that's what we see in MS as well. The lymphocytes, which are the target cells here, went down. That gives us a biomarker. That means we are hitting our target. It means that we've done the same thing in people with ALS that we saw in people with MS. And it means that if we're going to affect the immune system, or if we want to affect the immune system, we're seeing that effect. The drug, appeared very safe. Again, we aimed to enroll 30 people. Only 28 people ended up enrolling because we had to take people out of the study prior to their getting drug. There were 30 people who entered, but only 28 were exposed to the drug. We didn't see any decrease in the vital capacity or the FEV1, and there were no what we call serious adverse events, which means somebody had to visit the hospital or there was a life-threatening or very serious complication. So that's all very exciting, and I think that clears the way for a next step with this drug, which would be to look at a larger population, leverage our biomarkers, and look at efficacy. That is, does it work or does it not work? The last thing I would say is that we have an RNA analysis which is ongoing. So if we remember that DNA is the genetic material in cells, RNA comes out of DNA, and then protein comes out of RNA. So RNA tells us what gene is turned on and what gene is turned off. And what we found is that we can analyze RNA and get a lot of information about how we're affecting cellular mechanisms. And we're going to follow that thread forward to say how are we affecting the immune genes, what's turned on, what's turned off. We have tried lots of ways to completely shut down the immune system over the years, including the radiation and bone marrow transplant, and those have not had the beneficial effects that we were looking for. We now think that tweaking the immune system is probably good. Another study that completed in last fall, I believe, is a study of mexilotine, and I told you that, I'll show you the data, but I told you that it has an effect on cramps. What it's really being looked at for is whether it might have a slowing effect on the disease. Now, mexilotine is an old cardiac drug, and it works on sodium channels. So it works to quiet overactive cells. In ALS, we have known for quite some time that there is hyperexcitability, that the cells are more likely to fire. And in fact, our one effective therapy is riluzole. And riluzole is thought to work on the same mechanism, but in a different way. So it quiets the transmission of signal from one motor neuron to another. So mexilotine has strong reasoning. There's some animal data supporting the fact that it may slow the disease. And Michael Weiss at University of Washington took this forward into a trial. The trial had 90 participants. They were on the drug for 3 months. There were 2 dosage levels that were investigated and a placebo. And the primary outcome of the study was safety. But again, along the way, the idea is to get a readout on how it's working. And one of the readouts they looked at were cramps. So there were some side effects. If we look at the side effects that were significantly different in people who were on the drug versus not on the drug, there were some people who developed tremor, and nausea was a substantial problem. But these are really only in the highest dose group, and it went away when people went to the lower doses. We did not see cardiac arrhythmias, that is irregular heart rhythms, and that was something that I know Michael was looking very closely for throughout the trial. So this is the data showing reduction in cramping. So the white circles are the placebo, and the filled-in triangles and squares are the 2 different dosages of the drug. And we saw this early, we saw it throughout the trial, and I think this is a big win. It gives us another tool in our toolkit for people who are having this symptom. Now, we also, Michael looked at the effects on the ALS-FRS-R over time, and the idea was to try to look to see if there was an effect. We know, off the bat, before the study starts, that over a 3-month period, it is very, very difficult to see a difference, even in an effective drug. You can model this statistically, and you can say that unless a drug is really, really, really stopping this disease in its tracks, not just slowing it, it will be almost impossible to show at 3 months or less. So I would say all of these overlap. We don't see an effect. But the study really was designed to look at safety. So I don't take this as a discouraging thing at all. This is just the reality of clinical trials. Small numbers of people, not enough time, you're not going to see an effect. So this really sets the stage for a larger trial and a longer trial where we can look and see whether it slows the disease in people the way that it does in the animal model. So those are a couple of, I think, exciting recent trials that I think provide us with a way forward for a couple of drugs. There are a couple of ongoing trials I want to talk about. One of them comes out of data from plasma urate. Now, urate goes by 2 names, uric acid and urate. And it's found in the blood, it's found throughout the body, in the spinal fluid, and in the CNS tissue, that is the brain and spinal cord. It's fairly ubiquitous, and it is one of the major antioxidants in the body. We know that oxidative stress is a thing that happens in this disease. It seems to be something that motor neurons are very susceptible to. And if we had a way to reduce oxidative stress, that may be a big thing. Uric acid, it turns out, is lower in people who have a faster progression of this disease and lower in people with ALS than in controls. Now, there's some conflicting data about this. I'll say that off the bat. That's true of almost all of our biomarkers. It's not quite so clean as that. But there are a number of studies that show the same trend. So here we have the sort of percent decline in ALS-FRS over time, and here are the serum urate levels. The higher the urate levels, sort of the slower we are on the scale of how much the ALS-FRS declines over time. There's a drug that's on the market. It's actually available over the counter, which is hard to figure out because it actually has some side effects that really should be monitored. It increases uric acid in the blood. Because we think that people with ALS have a lower than average uric acid in their blood, and because we think that having a lower than average uric acid or lower uric acid than other people with ALS may confer a faster disease progression, we think raising the uric acid may be a beneficial thing to do. Now there's some other data to support this. That is, there's a researcher named Michael Schwarzschild at MGH who's looking at Parkinson's disease. He's run a phase 2 trial. He's poised to do a very large phase 3 trial in Parkinson's disease. His data is looking very promising as far as slowing the progression of Parkinson's disease. He's also looked at urate in mouse models, and he's found that urate induces the release of something called glutathione. Now, glutathione is a known antioxidant, very powerful in the CNS. It would be very compelling to say we should put patients with ALS on glutathione, but it doesn't cross the blood-brain barrier well. So this would be a way of sort of reaching across the blood-brain barrier and potentially inducing glutathione. So Sabrina Paganoni, who's in our group, is doing a pilot study of inosine in 30 people with ALS over about 12 weeks. Again, one of the primary outcomes here is safety. High uric acid, while it has all the benefits potentially that I've talked about, can cause gout or kidney stones. So we need to keep an eye on that. And we're not aiming to make this sky high. We're looking for a sort of high average or upper limit of normal. And that's why I think this really needs to be monitored. We need to do blood tests, pretty frequently to keep an eye on that and target the right level. She's included MR spectroscopy for glutathione. So this is a special way of using an MRI machine so that you can look not just at an image, but at how much of a certain molecule is present in a region of the brain. And we have some partners in our imaging group that have honed this to look at glutathione. So if things are working the way that we think they are, when we treat people with inosine, their uric acid will go up in their blood, and the glutathione will go up in their brain. And this would give us an imaging biomarker that we could follow over time in a larger clinical trial. We're obviously also looking at the plasma uric acid to be sure that this drug raises the uric acid the way that we think it will. Another trial that's ongoing is the trial of diaphragm pacing for ALS. So the diaphragm pacer is actually a device. It's shown here. This is an external pacing device. It connects to a plug, and there are wires that go in and lay over the diaphragm. It actually stimulates what's called the phrenic nerve, which is the nerve that goes to the diaphragm. This is a device that was developed originally for people with spinal cord injury. And there are some substantial differences in what's going on in people with spinal cord injury and what's going on with people with ALS. And one of the major ones as it relates to this device is that people with spinal cord injury, a complete spinal cord injury, don't have sensation. And so the spinal cord, the diaphragm pacer can be set at very high settings and stimulate the diaphragm to actually contract and draw in a breath. And people who are paralyzed below their neck and use this device instead of a ventilator for periods of time, draw in a breath. The difference, the substantial difference in people with ALS is that sensation is intact. That level of stimulation would be very painful. So that is not the use of this device in people with ALS. But the reasoning is that they did sort of a biomarker study looking at the thickness of the diaphragm and showing how that declines over the course of disease with ALS. And the goal is actually to deliver smaller shocks periodically to the nerve going to the diaphragm that are tolerable, quite tolerable, but may exercise the diaphragm and maintain the thickness of it. The company did one study. The FDA was sort of happy that it showed safety of the device, but there were some statistical problems, and the device was approved, but only on sort of a research ongoing basis, what's called a humanitarian use approval. And there needed to really be more data about this to understand whether it works or not. So the trial is going on now. It's to understand the impact of this. And it's looking at sort of vital capacity and other pulmonary function tests. It is randomized, so half of the people get randomized to having the pacer placed and half to not having it placed. But you can imagine that that's complicated. Normally what we do is we have two pills that we give to people. One of them is placebo and one of them is active study drug. But what do we do here? And that's a complicated thing when we're designing studies. The decision in this case was to do nothing to the people that were randomized not to have the device, to do what we call standard of care. So they can pursue all of the care that they would normally pursue in clinic, and even potentially other trials, but they wouldn't have the device implanted. So it's not what we call blinded. That is, everyone knows whether they were randomized to get the device or not. It's an easy check. Do I have a device or? There is some data out of Europe in a trial that was analogous, that was presented at a meeting, has not been published, that suggests that in that trial, people who had the device implanted were doing worse. And I can't give you more details than that. I would say that they're enrolling patients who are further along in the disease than the group that is eligible for the study in the US. And there is a team that's actively looking at all of the data from the study thus far in the US to determine what the safety signal looks like. I think it's more important than ever that we have an answer to this, because we now have one study that looks promising and one study that does not. And there's more information to be coming soon. So that's something I would say keep an eye on. I think in order to answer this question, certainly if there's a safety signal, you have to stop a study like this. But otherwise I think you can keep a very close eye on it and try to get as much information as possible as more information comes in from the other study. There are a couple of stem cell trials that are going on in different phases, either enrollment or follow-up. And again, just to reiterate what Nick said, there are really two ways that we can imagine using stem cells in people with ALS. One would be replacement of motor neurons. And the other would be support of the motor neurons that are there. So sort of sending good guys in to sidle up next to the motor neurons and support them and prolong their survival. And that's really the one that all of the stem cell trials that we hear about now are going after. And there are, as you heard, in a lot of detail from there, there are a couple of different approaches to this, or myriad different approaches to this is really a better way to say it. But Brainstorm is a company that's running a stem cell trial here. This is based on a phase 1 trial that was done in Israel. And this is bone marrow derived, what are called mesenchymal stem cells. So these are cells that are in the bone marrow. They can turn into not any cell type in the body, but many cell types in the body. And one of the key things is that the technology that Brainstorm has brought to the table here is a technology to grow these cells in culture and goose them along to secrete what we call neurotrophic factors. And neurotrophic factors are proteins that are secreted, in this case by the stem cells, and are beneficial to motor neurons. They're almost like fertilizer for motor neurons. And the idea is to put these cells in so that they act as little factories to produce these beneficial proteins. And this is a picture that shows mesenchymal stem cells before they go through the process of growing in a petri dish to sort of cause them to create these, produce these neurotrophic factors. And over here, the green is the actual neurotrophic factors, and there are two different ones shown here, GDNF and BDNF. There are others, I just happen to choose these to demonstrate the point. But you see that after they go through this process of differentiation, becoming the neurotrophic secreting cells, you see the neurotrophic factors show up, and you don't see that in the before slide. The trial is a randomized, placebo-controlled, blinded trial, so all the things that I talked about before. It's a 3-to-1 randomization, so most of the people, 75%, will get the active treatment, but 1 out of 4 will not get the active treatment. And none of us know. We've gone to great lengths to blind this so that neither the investigators, and I am involved in the trial as an investigator, nor the patients know what's being delivered. We, in fact, have a separate team that goes in and does the stem cell delivery just to be sure that I, as the person who's sort of assessing the patient, never even sees the product that they're getting. It's 48 patients at 3 centers. There's a screening and an observation period so that we try to get a sense of slope of decline before and after the stem cell treatment. We have to do a bone marrow aspiration. That's a surgical procedure. It's done in the operating room. We take the marrow, we send it for a month to a stem cell facility. It comes back to us and we inject it. We inject it in 2 places, into the spinal fluid and into the muscle. And the idea is that when we're injecting into the muscle, these neurotrophic factors might be taken up by the neurons and transported through the axon back to the cell body. And then people are followed up for 6 months after the treatment. Again, safety is sort of the main purpose here. Efficacy, or whether it's effective, is also, we can't help ourselves. We need to look at that. And we'd like to get an early read on it, and we'll see what the data shows. It's very difficult to have a biomarker in this kind of a study because we're taking cells out from people, we're putting the same cells back into people. And to track those cells is really difficult. There are some technologies that are out there that may be important as we go forward. There are ways to put iron molecules, very tiny particles of iron into a cell and label it. But there are some challenges there, like if you put them in, you know that the cells went there, but you don't know whether the cells are alive or not. Those are the kinds of questions that we struggle with answering. But I think it's a good first step. The other company that's doing a trial in the US, which is ongoing follow-up phase right now, is Neurostem. And this is a picture of the spinal cord where the cells were actually injected. You can see where they've taken up residence. In this case, the cells are delivered to the spinal cord. If you tell most any neurosurgeon that you're putting a needle into the spinal cord and delivering anything to the spinal cord, they would grimace. Nick Boulis has done hundreds and hundreds of surgeries on mini pigs and developed a whole apparatus to make this as safe as possible. It is a huge part of this project. It's the same process that you heard about from Nick. This has been incredibly carefully done, and that in and of itself is a feat and a win with lots of potential downstream benefits that we can't even predict. There was one patient in the early studies who improved, and I think that's being chased in a number of ways. One of the ways is a study that I'm not going to talk about today, but I'll mention here just to say that we have a study where we're treating people with immunosuppression. The cells used in Neurostem are non-self cells, so they're not from the patient themselves. In order to protect those cells in the same way that we would protect a kidney transplant, we put people on immunosuppression. One of the questions that comes up is any of this improvement in this one person seen as a result of immune suppression? So we have a second protocol that's going on where we do the same immune suppression, but no stem cells, and you see what that shows. There are a couple of trials starting soon that are more than the ones I'm going to talk about. I won't talk about Q therapeutics, you've heard about that already. Tirasemtiv is a drug that's been through phase 1, a number of phase 2 studies that I think were very carefully designed to learn lots of pharmacokinetics about the drug, how it behaves, what its levels are, how it interacts with other drugs, and what its potential beneficial effects are. This is really based on an electrodiagnostic biomarker. That is to say, when they started, they did what amounts to an EMG. They gave shocks of electricity to a nerve that went to the muscle that lifts the foot up. They measured the force of the contraction of the muscle, and they gave different dosages of the medication, and found that the higher the dosage of the medication, the more strength they got out of that muscle when they contracted it. In the most recent trial that was done, there were a number of outcome measures that were looked at. There were 2 that were significantly positive. One was the vital capacity, which is a measure of breathing. It's the one that we measure every time a patient is in clinic, or almost every time a patient is in clinic. It gives us a good sense of respiratory strength. And the other one was what we call a megascore of strength. So this is a summary of muscles that we've tested in a quantitative way to look at strength. There were a number that were not positive. And I think the question is, what does that mean? And the way to answer that is to go on and do an even bigger study. But this is I think, really potentially good evidence that the drug is working the way that I think that it will. So the next step is a bigger trial, phase 3. The next study is retigabine, which is the one that Nick hit on briefly. So this is a drug that is on the market. It's an epilepsy drug. It came out in a screen of drugs in induced pluripotent stem cell-derived motor neurons. So these are motor neurons in a petri dish. And Brian Wanger at Kevin Edmonds' lab, Provo's lab, looked at how the stem cells and motor neurons from the stem cells from people with ALS behave differently than people without ALS. And in fact, they did something very clever, which was to take stem cells from a person with SOD1 ALS, take that mutation out so that they created sort of stem cells that were exactly the same, with the exception that they had a normal SOD1 gene, and looked at how those behave differently. What they found is that there was hyperexcitability, more discharges from those neurons in those with ALS. They then went on to screen a number of compounds that they thought would be effective in decreasing this hyperexcitability. And the one that was most effective was retigabine. It's known to do this. Epilepsy is simply overactivity of certain neurons in the brain, so it makes sense that they would have the same activity in neurons in a petri dish. And the next step was to translate that into humans. And so this is an example of going petri dish to a drug which is on the market, which means that there's a much clearer path to repurpose it for ALS, which gives us more bang for our buck. We can skip a lot of the early development costs. We can get much more quickly into people. And the plan is to enroll 192 people with ALS into 3 groups, placebo, and then two different dosage groups. And I think the study team has done an incredible job of creating biomarkers, developing them, working with groups from around the world, England, Australia, and within the US, to find markers that will tell us about excitability. So I think that this is a really exciting demonstration of where we're moving in clinical trials, which is from a preclinical model, that is, whether it's a mouse or a stem cell model, or both, or neither, maybe it's a fruit fly, but understand the pathway and the science, take that into people, and create biomarkers that tell us about how it's working in people and whether it's hitting those same targets. I think this is really where we're going. I'm running out of time here, but I'll hit on a couple other ones that are coming up. So there are a number of markers that suggest ALS progression progression correlates with inflammation. I've chosen one to put here. This is called miR-155. miR-155 is an upstream regulator of inflammation. It's kind of a master regulator of inflammation. And it seems to be upregulated in people with ALS, both sporadic and familial ALS. So probably not the whole enchilada, but may well be involved in the progression of the disease. There are also studies from cerebrospinal fluid saying that there are more pro-inflammatory proteins present in people with ALS. There are a number of sort of lines of reasoning coming together. And we have a lot of different trials at various stages of preclinical work, but one coming to people very soon of a drug called tocilizumab, or the brand name is Actemra. That's a little easier to say, so I tend to call it Actemra. It blocks IL-6, which is a protein that is pro-inflammatory, so it decreases inflammation. Again, there's a clear pathway to getting it into people because it's already been in people for other indications like rheumatoid arthritis. Shafulada, who's out at Barrow, is putting together a study that will be 16 weeks long, 32 patients, randomized 2-to-1. This will be very biomarker heavy, very biomarker driven. So there'll be biomarkers from the CSF. They're also going to collect blood and look at blood markers as well as blood inflammatory cells as biomarkers, and see how we're changing the pathways that we're targeting here, and then correlate that to any clinical information that comes out of the trial as well. I'm going to hit on telehealth. I know I'm running a little bit late, but I wanted to say a few things about this. So the ALS Association a few years ago funded our center to begin looking at how we might use telehealth. And there have been a number of lessons that come out of it. I'll try to summarize these very briefly. So the definition of telehealth is probably broadly the delivery of healthcare-related services and information via telecommunication technologies. And we do a lot of this in our multidisciplinary centers. We do a lot of phone calls. Increasingly, we do a lot of emails. We get pictures from people now. This is what my YouTube looks like, or here's my, here's what my hand looks like, or please help me with this. And I think we're really always trying to keep up with people, but we're sort of incorporating some of this automatically into what we do. But I think the connotation when we talk about telehealth and telemedicine is that we really look for new ways to leverage technology to make the delivery of healthcare better. Consumer telehealth is here. So there are weight loss devices like the Happy Fork that tells you when you're eating too much, and the Fitbit that a lot of us are familiar with. There are sort of body fat monitors. One more example there, but there are lots of these things, and they're proliferating, and some of them are built into our phone. I actually looked at my iPhone a little while ago and realized that since I bought it, it had been tracking how many steps I've taken a day. Since I found that, I've actually really been trying to walk more, and I guess it works. And I always carry my phone with me when I walk because I want credit. So it's bad, like a bad day is when it runs out of batteries. Because you're like, I need someone else's phone and then I need to transfer my credits. But I think medical telehealth is on the horizon, arriving and in some cases here. I think one of the things that's been sort of slowing us down is some of the privacy issues, some of the fidelity issues. I mean, it's one thing to have a consumer device that tells you your body fat and is off by 20% sometimes. And we all sort of accept that it's a device, it's fun, and maybe it helps us think about our weight. But it's a little different when we bring it to bear in a sort of a clinical setting. So there are higher bars, and I think at a different level of evidence that we need to bring to bear. Reimbursement is an issue, and I think just the conservative culture of medicine. We know how we've done things, we're comfortable with that, and this sort of makes us a little bit itchy. There are examples that we're already doing. So some of the metal bracelets, you don't push a button, it just knows when people have fallen, and it can automatically call for assistance. So we're already using these even in medical settings, clearly. But we implemented, as a part of this project, we implemented video televisits. And I have to say that I learned some very, maybe in retrospect, obvious lessons. But I think they're not obvious when you wade into this. So one of the things is that patients like it. People really like this. I have never had somebody say to me, gee, I wasn't crazy about that. I wish we had done that. I've had people say, I want to continue to see in clinic, but let's do this periodically as well. This is the one that I was actually least certain about when we delved into this. providers like it. It's actually very simple and it's a nice way to deliver care. And I have to say, I get information about people that I don't get in the office, because when people come to the office, they spend time putting on their makeup, putting on their Sunday best, really. They think about the appointment for weeks. It's a big deal. And I see them at their best, and I see them in my house. And my house has been designed to make it easy to get around. And the bathroom is accessible, and Hoyer lift fits everywhere in my mind. But that's not true at home, and I can see those things. I think one of the, I'll skip one bullet point here, one of the big things that I've learned is that using this in conjunction with home health organizations has been the biggest win. Because that gives me a chance to talk with the people who are in patients' homes and helping them. And they can say, you know, I've been noticing this, can we look at this together? Or what's your suggestion about this? They can help clarify what a patient is trying to convey to me. They can give their perspective. It makes us a team, it gets us on the same page, and we can troubleshoot all together. That's been one of the biggest wins. Actually, as a result of that, we put together a team where we went out to the biggest home health organizations, parts of our multidisciplinary clinic, and we put together lectures where we could talk about ALS, answer their questions about people they were taking care of now, but also give them the basic information about caring for people with ALS at home. How important it is that transfers be done very, very cautiously, and you have a conversation about that before you just start grabbing people and moving them. Not that no one has bad intentions here, but it's different than taking care of people who are surgical and getting better, or have congestive heart failure, or whatever the other common causes they're seeing. The other thing I would say is that complex programs are too cumbersome. So when we first started this, I put in all kinds of very complex programs. It's going to be this often, and it's going to be spread out this way, and we're going to do consent, and they're going to do this and that, and it was just too much. We really backed off. We cut down to what we really wanted to get out of this, which was, can we do it? Is it helpful? What's the goal for it? Do people like it? Do providers like it? And that's how it's really been at its best. We found that we can extend care to patients that we just would otherwise have lost touch with, or maybe had some phone calls with here and there. We've really been able to stay in touch with them. And I think, we're still working out what's the best, what's the best way to optimize this? How often do we do it, and how do we work it into our clinic? We're now working with a group at MGH to develop what we call asynchronous telehealth, which is kind of ways of sending out automated surveys and getting answers back that we wouldn't normally get any answer about. So we start somebody on Billy's, I'll send them a survey automatically in a couple of weeks that asks a few questions about how they're doing. And if they're having GI upset, we can deal with that right away, rather than putting the onus on them to tell us about it. So that's, I think, a really exciting extension of this as well. It ties into some things we're doing with our website. And it also ties into some efforts that we have to kind of use things like monitoring foot drop, or monitoring weight, in this case, to make sure people aren't losing weight, to give them input on how to do that. There's a project that's going on at ALS at NEALS to do this specifically. And I think we're going to try to tap into phones and accelerometers and learn about this from a research perspective and a care perspective. So again, I have to thank too many people. It would be the rest of the night to thank all the people at MGH that I work with, through the Northeast ALS Consortium, the ALS Association for their help, and many, many patients that we see in our clinic and in our research studies. Happy to take questions. Sorry, I'm
One of the first screens you have through your web, www.alscon, and it's clicked too quick. Is it able to go back to that screen or give you a web?
Yes. This was a website? Was it for
Could you repeat the question?
It was probably ALS Consortium.
Yeah. So I think there was a question about a website. So we can actually flip back to it, but there is the Northeast ALS Consortium, which is the collaboration of about 114, maybe more now, centers across North America, and it's really kind of the major organization that's driving clinical research in conjunction with organizations like the ALS Association. Their website is www.alsconsortium.org. This is a website that NEALS has put together with huge support from the ALS Association. It's actually a wonderful resource to find centers near you, but also to find clinical trials that are going on. There's There's a section where you can ask an expert questions, and there are webinars that are put on by various folks, but funded by the ALS Association to address a lot of clinical research questions. So thank you for pointing that out.
The brainstorm trial has been on for several years. Any results in the long-term effects, please?
So yeah, so the phase 1 studies have been going now. Yeah, absolutely. So the question is, the brainstorm studies have been going on for some years now. What do we know about the long-term effects of the treatment? So the phase 2 study here in the U.S. started about a year ago. We don't have results from that study yet. That one's ongoing. The phase 1 studies and early phase 2 studies that they ran in Israel, the safety out of those looked good. They have been looking at, again, we can't help ourselves. We start looking at effectiveness as early as we can. It's very hard in the small numbers of people that they were treating. I would also say that they were sort of, in the beginning, working out what the best paradigm would be for delivery of the cells. So some people got muscular injections, some got intrathecal, that is into the spinal fluid, and only a few got both. So it's a mixed bag in those early studies, and they did exactly what they needed to do, which was inform the larger studies going forward. It's looking safe, and I think there were some hints in there about efficacy, but a very small numbers. One of the questions that comes up is that Nick hit on this tumorigenicity. These are early differentiated cells or undifferentiated cells. That is, they can turn into lots of different cells, but that is actually a good way to describe a cancer cell as well. There are some differences in what genes are turned on and off, and it turns out that none of these stem cell trials have really shown that as
They start using neuroprojectors in this one.
say again.
The neuroprogenitors.
So the question is, where are they using neural progenitor cells? So the cells they're using are actually further back than that. They're mesenchymal stem cells. So they can turn into any one of a number of cell types. Yeah.
I guess my question is kind of for all three speakers. You've mentioned this C9orf mutation, which I guess is really an expansion, it's like a 6-nucleotide expansion. So that really sounds similar to the Huntington expansion. And I guess my question is, for your genome sequencing project, is there a concern that you'll miss those kind of expansions in an unknown gene?
Yeah, so the question is, so C9orf72, the mutation is an expansion of 6 nucleotides in a row. It just sort of repeats and repeats and repeats, and there should be a couple of them, but there are lots of them. And this is exactly the same thing, or very, very similar thing to what we see in the Huntington gene. And using some of our sequencing techniques, we can miss this. So the question is, in these large-scale efforts that we have, is there a concern that we will miss this? I might let Nick and Lucy weigh in as well. I would say, number one, a lot of our sequencing is being optimized to be better at catching this. But yes, it is on everybody's mind. And it may be that just doing one kind of sequencing, so just sequencing may not be enough. You might need to have methods for looking for repeats. This is actually a really big effort on the genetic side of things to develop ways to screen large segments of the genome or the whole genome for repeats. And it's tricky, but we're getting there.
Yeah, the new technologies being employed to do that.
Lucy says there are new technologies being employed to do just this. And I think, I think the real take-home point here is that we see what our technology allows us to see. And the holes in our knowledge are the unknown unknowns. So we didn't know for a long time that we were missing this hexanucleotide repeat expansion. We were sequencing and sequencing and sequencing and missing it. In retrospect, to say, well, of course, we weren't using a tool that would show us that. So in some ways, it's a lesson to say, for us to take a step back and say, what are our tools not able to show us now? How do we develop new tools to be able to do those things?
Diaphragm is used currently to treat epilepsy, and they're doing trials to see if it will work with ALS patients. Since there are some symptoms that are similar in both illnesses, is there a way to have it dispensed to a patient with ALS now?
So the question is, Diaphragm is on the market for treatment of epilepsy. There's a trial going that's going to start imminently for ALS, but is there a way to have access to it outside of the trial? So the answer to that is that it's a drug that's on the market and it can be prescribed what we call off-label. That means for an indication other than what it is. So the short answer is that's possible. The more complex answer is that this is a drug that is rarely used in epilepsy because it has some substantial side effects. I didn't go into that as much, but we know that this drug can cause substantial urinary retention, difficulty with urinating. It can cause discoloration of the skin, or more importantly, discoloration of the retina, which can interfere with vision. It can have sedation as a side effect. So these things need to be monitored really closely, and I think, in some cases it may be the right thing to do, in some cases not the right thing to do. My perspective as a clinical trialist is that if there's a way to be involved in a clinical trial, I think it's the best safety monitoring and it's moving the ball forward as well. But I think that's a discussion that anybody who's thinking about it should have with their